practicing physicians, and of course, other health workers. Registration is free. The webinar runs on the UP Manila live streaming platform at livestream.upm.edu.ph. If you have difficulties in accessing the webinar through the live stream page, please watch the FB live video on our Facebook page. This session will run for an hour with 30 minutes allotted for lectures, followed by a question and answer portion which will be moderated by Dr. Hazel Manapatri. To participate in the webinar, please use the Q&A box found on the live stream page or by texting your questions to 0915-259-9686. For Facebook Live participants, please type your questions in the comments. May we now call on our moderator, Dr. Hazel Manapatri, who is a member of the celebrating class of UPCM 1994 and is an associate professor of the PGH Department of Medicine, section of Rheumatology, and is the assistant to the associate dean for academics. Dr. Reyes.
Thank you, Seth. Our time now in Manila is 12:01 noon time, and I'm speaking from the video conferencing room of the UP Manila IMS Padre Fowler Street, Ermita, Manila. Welcome to all of our participants this afternoon. Today's webinar is entitled Dyslipidemia Management in Patients with Hepatic and Renal Impairment. I'm sure you're excited to listen to this. And this afternoon, our speaker is going to talk about the following issues. Number one, discussing the key points and major recommendations of the Philippine Clinical Practice Guidelines on dyslipidemia. Number two, describing the current approaches to addressing dyslipidemia, focusing on LDL-C reduction. And two, to analyze the approach to managing dyslipidemia among patients with hepatic and renal impairment. Let me introduce this afternoon's speaker. She's Dr. Lourdes Gonzales. Luella is a graduate of the UPCM class of 1994 and subsequently did her internal medicine residency at the State University of New York I, or SUNY, in Brooklyn, New York, USA. She then came home and was certified as an internist, then stayed to take cardiology fellowship at the Cardinal Santos Medical Center. She left afterwards to continue to train and took further subspecialty training on preventive cardiology, hypertension, and a clinical lipidology fellowship at the New York University. She's a certified internist and cardiologist both locally and in the U.S. She's a clinical associate professor at the section of cardiology of the Philippine General Hospital and is a training officer of the cardiology fellowship program of Cardinal Santos Medical Center. She remains to be the only certified lipidologist in the country and was the head of the Technical Review Committee on the development of clinical practice guidelines for dyslipidemia in 2015. May we now call on Dr. Luella Gonzales for her lecture.
Good afternoon. So, having seen the flow of today's discussion, which is entitled Dyslipidemia Management in Hepatic and Renal Impaired Patients, I want you to walk back through history, back to 2015, when a group of physicians comprising the fields of cardiology, endocrinology, clinical epidemiology, and lipidology were tasked to update the prevailing clinical practice guidelines for the management of dyslipidemia in the Philippines. And this was of prime importance because the prevalence of dyslipidemia, based on the last 3 national nutrition surveys, shows an increase in the trend of total cholesterol from 33% to 46%, mostly driven by elevations in LDL cholesterol and triglycerides, also by an increasing prevalence in low HDL cholesterol in the Philippines. And so it was of prime importance to be able to update guidelines so that we know how to manage Filipinos with dyslipidemia. Understanding that the cornerstone for dyslipidemia management is always going to be lifestyle modifications, where in individuals at any level of cardiovascular risk, a low-fat, low-cholesterol diet rich in fruits and vegetables is recommended. Smoking cessation is strongly recommended, and exercise recommended. And the reason why we look to guidelines is because we want to be able to set our goals as physicians for managing dyslipidemia. Understanding that guidelines now are very statin-centric in that absolute cardiovascular event rates in randomized clinical trials show that statin is cornerstone in LDL cholesterol reduction, whether we talk about secondary prevention trials or primary prevention trials. And I think a publication in 2015 very aptly placed it that we don't prescribe statin therapy to reduce LDL cholesterol, but we prescribe it to reduce atherosclerotic cardiovascular risk. And that's the reason why most guidelines are still concentrating on using statin therapy for dyslipidemia management. Having said that, our guidelines are very parallel with these goals for LDL cholesterol reduction using primarily statin therapy. So in the 2015 updated clinical practice guidelines, we identified populations or at-risk individuals who need to be treated with statin therapy. And we're going to go through these populations in the next few slides. So the first population are those in primary prevention. For non-diabetic individuals, more than 45 years, with an LDL cholesterol of more than 130 and more than 2 risk factors, without documented atherosclerotic cardiovascular disease, we recommend that these patients be placed on statin therapy. We have included in the 2015 guidelines a list of these risk factors so that you can enumerate for patients you're seeing with primary prevention. And the reason why we list down these risk factors is because up to date, we have no ASCVD risk estimator to be able to see what Filipinos' risks are. Unlike the American guidelines, which has an ACC-AHA risk calculator to determine risk factor counting is all we have here in the Philippines. So, if you have a primary prevention patient who is more than 45 with more than 2 risk factors with an LDL of more than 130, then you should start these patients on statin therapy. In the 2015 guidelines, we have actually also put a caveat in very high-risk individuals that you should identify for primary prevention. And these are patients who fulfill the criteria for the diagnosis of familial hypercholesterolemia. Knowing fully well that these patients with familial hypercholesterolemia are at very high risk for developing atherosclerotic cardiovascular disease because they develop myocardial infarctions in the first or the second decade of their lives. So, in the 2015 guidelines, we've actually placed a checklist where if you point score your patient's family history, clinical history, or physical examination, as well as laboratory values, you can actually score a definite familial hypercholesterolemia if their point score is more than 8. Probable, 6 to 8. Possible, 3 to 5, or unlikely, less than 3. What's beautiful about this Dutch lipid network criteria is just on the basis of a significant family history, clinical history, and physical examination, you can actually diagnose familial hypercholesterolemic patients even without LDL cholesterol levels or without DNA analysis. So it's important that these patients be identified because these high-risk individuals should be on aggressive statin therapy for LDL cholesterol lowering. When we move on to primary prevention for diabetic individuals, in the 2015 clinical practice guidelines, we've recommended that for diabetics without atherosclerotic cardiovascular disease, statins should be started. And we get a lot of questions about placing fibrates in these patients for primary prevention. Understand that in the 2015 guidelines, we do not recommend fibrates as an alternative to statin therapy in the primary prevention of patients with diabetes. When we move on to secondary prevention, all individuals who have had a myocardial infarction, who have had a stroke, who have had bypass, stents, carotid artery disease documented, or peripheral arterial disease, and these are patients with secondary prevention, they should be on statin therapy. Again, we get a lot of clinical questions about the use of fibrates in patients with secondary prevention or omega fatty acids. And in the clinical guidelines, we do not recommend fibrates as an alternative to statin therapy, nor omega fatty acids as an alternative to statin therapy in patients who have had an event already, or patients with secondary prevention. Moving on to a very high-risk population, these are patients who have had NSTEMI or STEMI or myocardial infarction patients. These patients with acute coronary syndrome should be on early, high-intensity statin therapy. Early meaning these patients should be instigated on diagnosis or within 3 to 5 days of diagnosis of acute coronary syndrome, be started on statin therapy. And the recommendation that we've adopted in the clinical practice guidelines for statin treatment intensity is the same as the American guidelines looking at statin intensity, where statins that can reduce LDL cholesterol by less than 30% are termed low-intensity statin therapy. Statins that can reduce LDL cholesterol by 30 to 50% are moderate intensity statin therapy, and statins that can reduce LDL cholesterol by more than 50% from the patient's baseline are high intensity statin therapy. Remembering that there are only 2 high-intensity statin therapies that are locally available, and this is atorvastatin at a dose of 40 to 80 milligrams, and rosuvastatin at a dose of 20 to 40 milligrams. As a group, the Technical Research Committee made recommendations not just on statin therapy but also on combination therapy. But we only recommend combination therapy on top of statin therapy if LDL cholesterol goals are not met. So the recommendation for combination therapy is only to attempt further LDL cholesterol reduction, but monotherapy with statin comes as first line or cornerstone in dyslipidemia management. This chart that is included in the 2015 guidelines shows the percent reduction in LDL cholesterol with particular non-statin therapies. Fibrates can decrease LDL cholesterol by 5 to 20%. Ezetimibe can decrease LDL cholesterol by 18%. We wanted to remind Filipino physicians that if you give omega fatty acids, you can actually give a 5 to 10% increase in LDL cholesterol in patients, and that's the reason why we do not push for it as an alternative to statin therapy. We've also included changes in triglycerides for fibrates, omega fatty acids, and ezetimibe. And all of these recommendations are summarized in an algorithm for patients treated for dyslipidemia, where when you identify them, statin therapy should be started. So in patients with diabetes or atherosclerotic cardiovascular disease, these patients should be on statin therapy and of course cornerstone lifestyle modifications. If you have a patient more than 45 years with more than 2 risk factors, with an LDL of more than 130 milligrams per deciliter, these patients should be on statin therapy. And of course, the last at-risk treatment group are those patients who fulfill the criteria for familial hypercholesterolemia. So understanding and identifying these patients at risk who should be on statin therapy is important because that is when dyslipidemia management is indicated. Now, the fear for starting statin therapy and in some physicians is that risk for inducing drug-induced liver injury. And so we move on to hepatic impairment. When we have patients who are on statin therapy, it has become rule of thumb for physicians to get baseline liver function tests. And the fear for elevations of alanine aminotransferase of more than 2 times above the upper limit of normal or 3 times above the upper limit of normal should not be considered as something that we fear, because it is very common when we start patients on statin therapy to have slight elevations in liver functions. We call this transaminitis. Transaminitis is an elevation of liver enzymes in the absence of proven hepatotoxicity. When we see these in patients who are started on statin therapy, understand that majority of these transaminitis are asymptomatic, they are reversible, and they are dose-related. Asymptomatic and reversible, meaning without doing any additional therapy or without stopping statin therapy, these will eventually resolve. We don't particularly know the underlying mechanism why transaminitis occurs once patients are started on statin therapy. There is a hypothesis that when statin therapy is started, there is a change in the lipid component of the hepatocyte membrane, leading to an increase in permeability with a subsequent leakage of liver enzymes, causing that slight elevation in ALT. Of course, if the ALT is more than 10 times above the upper limit of normal, that is when true hepatotoxicity occurs. And that is the indication for stopping patients statin if patients are on it. The high rule criteria is something that we should watch out for too if we are considering stopping statin therapy once started. These are patients with ALT more than 3 times above the upper limit of normal, but the total bilirubin level should also be more than 2 times above the upper limit of normal so that it fulfills the criteria, the high rule criteria for drug hepatotoxicity. So at any time after starting a new drug, if this is seen, then the risk for drug hepatotoxicity is high. But otherwise, transaminitis is a consideration if the ALT is less than 3 times above the upper limit of normal elevation. And when they looked at the incidence of increase in serum ALT levels more than 3 times, understand that in clinical trials looking at high-intensity statin therapy compared to moderate or low-intensity statin therapy or placebo, no more than 3% of the studied patient sample actually elevated to more than 3 times the upper limit of normal, even when compared with placebo. These were eventually dose-dependent, similar for all statins, and most cases actually improved without stopping statin therapy or without additional agents to treat that elevation in liver function tests. And so in the 2015 guidelines, we came up with an algorithm for how to treat patients with elevated ALT, AST, while on statin therapy. If the ALT is less than 3 times the upper limit of normal, then the recommendation is to continue statin therapy. In the meantime, you can work up these patients for other possible causes of elevated liver function tests, especially if you have a high index of suspicion for liver failure or liver hepatotoxicity. If the ALT is more than 3 times the upper limit of normal, then it is indicated to stop the statin. But in those individuals with very high risk for cardiovascular disease, it is advisable to use other non-statin therapies to lower LDL cholesterol. We do want rechecking of ALT levels after 2 weeks. If there is resolution, then this can still be transaminase elevation or transaminitis, and there is still a recommendation to place patients back on statin therapy if after 2 weeks the ALT is still elevated but less than 3 times above the upper limit of normal. So you resume the statin at a lower dose, or you start with a statin from another class. If after 2 weeks of monitoring, the LFT is still elevated, more than 3 times the upper limit of normal, then you have to consider other causes of liver injury. And the reason is because we don't fear drug-induced liver injury when we're talking about statin therapy, because statins rarely cause drug-induced liver injury. The incidence is about 1 in 100,000. But of course, most commonly, and we see this frequently, is that transient benign ALD elevation that we call transaminitis. So statins should not be prescribed to patients with acute liver failure or decompensated liver disease, but otherwise they're safe for most patients with liver disease. So key message here, because we keep stopping statins in patients with transient elevations of liver function tests, is the incidence is very low. There is a direct relationship between the dose and the incidence of transaminitis, so consider reducing the dose. The incidence of elevation is similar regardless of which statin therapy, and most cases of transaminitis exhibit spontaneous improvement without the need for drug discontinuation. But what about particular cases where liver function tests are already elevated at baseline? So these are patients with non-alcoholic fatty liver disease. So patients with NAFLD have increased risk of ASCVD. Statins have been shown to decrease cardiovascular mortality in NAFLD patients. And in earlier clinical trials, such as the IDEAL trial, it showed that moderate statin treatment, high-intensity statin treatment with 80 milligrams of atorvastatin reduced by 44% the risk of secondary cardiovascular events in NAFLD patients. In the Dallas Heart Study that looked at about 638 residents with NAFLD, in patients who were on statin therapy, there was no significant difference for ALT elevations. And the most cited trial that looked at non-alcoholic fatty liver disease patients is the GRACE trial, where these patients were placed on atorvastatin. And despite the fact that their liver function tests were elevated at baseline when they were started on atorvastatin, not only did their liver function tests not worsen, but there was actually an improvement or a reduction in their liver function tests. So we know that statin treatment is safe. Not only that, but it can improve liver tests and reduce CV morbidity in patients with mild to moderately abnormal liver tests. And the latest evidence-based review of statin use in patients with non-alcoholic fatty liver disease is a 12-trial review looking at patients with NAFLD. Statin therapy appears to be safe in patients with NAFLD, although we don't know yet if they can be used to specifically treat steatohepatitis, hepatosis in patients with non-alcoholic fatty liver disease. So another common dilemma we have as physicians when we want to treat dyslipidemia in patients are those with viral hepatitis, particularly viral hepatitis C. Now we know that hepatitis C has increased CV risk. In hepatitis C, we see a manifestation of decreased serum LDL cholesterol and total cholesterol. But understand that this reduction in LDL cholesterol in patients with hepatitis C is not because of an overall reduction, but because it is virally mediated. That virus upregulates LDL receptors in the liver, and by virtue of increasing LDL receptors, it increases LDL clearance. So because of this, that reduction in LDL cholesterol confers no cardiovascular protection. So in patients with viral hepatitis C, statins are not only safe, but they're beneficial in these patients to reduce atherosclerotic cardiovascular disease. Same with hepatitis B. They're safe in patients with hepatitis B as long as it's tolerated. But what about those patients with full-on cirrhosis? So in patients with established cirrhosis and related complications, or those patients with chronic liver disease, is there a benefit to putting them on statin therapy? In a meta-analysis in 2017, looking at about 121,000 patients, they found that statin use was associated with a 27% lower risk of progression to portal hypertension in patients with cirrhosis. It was also associated with a 46% lower risk of hepatic decompensation in patients who were already cirrhotic. And what they saw was this reduction actually translated into a reduction in mortality, where all-cause mortality was significantly reduced in patients who were on statin therapy who had liver cirrhosis or chronic liver disease. So when we talk about cirrhosis, we know that there is a higher risk of coronary artery disease in these patients. Statins are safe and effective in these particular patients, although in decompensated cirrhosis, we do not recommend statin therapy. And recent evidence has come to light that statins may reduce portal pressure. What about non-statin therapies in dyslipidemia management in hepatic impairment? So I just wanted to show this particular table, which deals with non-statin therapies and their effects on the liver, where you can see that earlier add-on therapies like bile acid sequestrants can actually increase hepatic transaminases. But of late, what is locally available is ezetimibe, which has a low rate of serum enzyme elevations. And if these are added on top of statin therapy, you have to closely monitor the liver function tests in patients already at risk for hepatic impairment. So take-home message is in hepatic impairment, statins are safe, even in patients with chronic liver disease. They are contraindicated only in patients with decompensated cirrhosis and in patients with documented statin-induced liver injury. Now moving on to statins in renal impairment. When we talk about statins in renal impairment, understand that the difference is that in patients with chronic dysfunction of the kidney or patients with impaired levels of renal function, at whatever level of renal impairment, we know that CKD is a cardiovascular disease equivalent. 50% of patients with chronic kidney disease die of cardiovascular disease, and CV mortality is 30% higher in patients on dialysis. So much so that in our guidelines, the KDIGO guidelines for dyslipidemia in chronic kidney disease, patients at any level of renal insufficiency should be on statin therapy. So those patients with eGFR categories of 1 or 2, as long as they're more than 50 years old, should actually be on statin therapy, regardless of the amount of albumin or proteinuria in the urine. If the patient is in eGFR categories 3A to 5, the recommendation is if the patient is more than 50 years old, they should be on statin plus ezetimibe combination. If they're less than 50 years old, but they have known coronary artery disease, they've had a previous stroke, they're diabetic, or if according to the ACC 10-year calculator for risk of ASCVD, they score more than 10%, these patients should be on statin therapy. In patients with GFR category 5 on dialysis, if they're on statin ezetimibe combination, these should be continued, but it should not be started if these patients are not yet on statin combination therapy. And the basis for this recommendation was an earlier clinical trial called the SHARP trial. So the study of heart and renal protection randomized about 9,000 patients more than 40 years old with chronic kidney disease to simvastatin plus ezetimibe combination regardless of their baseline LDL cholesterol levels. And in this particular trial, the 32% reduction in outcomes translated to a benefit of placing patients on statin therapy even at lower renal functions. The KDIGO guidelines also gave their recommendations on the doses of statins in adults with chronic kidney disease, where you see that patients with EGFR categories 3 to 5 can be placed on atorvastatin 20, rosuvastatin 10, or the combination of ezetimibe 20 per 10. In 2018, the ACCHA gave their recommendations for cholesterol management, where in adults 40 to 75 years of age with an LDL cholesterol of 70 to 189 milligrams per deciliter with a 10-year ASCVD risk of 7.5% or higher according to the ACCHA calculator, CKD not treated with dialysis or kidney transplantation. These patients should be initiated on moderate intensity statin therapy or combination with ezetimibe. In adults with advanced kidney disease that require dialysis, LDL cholesterol lowering with the statin is indicated if they're on it to continue the statin, but if they're not on it, do not start these patients on statin or combination therapy. When we look to LDL cholesterol reduction and the risk of hospitalization for myocardial infarction by EGFR, we see that the relation between LDL and the risk for MI is linear at LDL cholesterols above 100 milligrams per deciliter. And that's the reason why National Lipid Association guidelines came up with their recommendations for goals of LDL cholesterol for patients with chronic kidney disease, where in most patients, an LDL cholesterol goal of less than 100 milligrams per deciliter is recommended, except in those patients with atherosclerotic cardiovascular disease documented, where the goal LDL should be less than 70 milligrams per deciliter because these are higher risk individuals. So the challenge of treating dyslipidemia in CKD patients is that patients with chronic kidney disease behave differently depending on their stage. So we know that statins are effective in CKD 3 than in patients on dialysis. And we don't particularly know why. It may be because there is a change in the nature of the vascular disease from primarily atherosclerotic to predominantly calcific pathology with myocardial fibrosis as kidney disease progresses. And we don't know what the underlying reason is why statins lose their benefit as renal failure progresses. So in 2017, they delved on a meta-analysis looking particularly at statin benefit in different stages of kidney disease. So they wanted to quantify the benefit of statin therapy and to determine at which point statins become less effective by examining where possible different stages of kidney disease. And in this particular trial, they found that depending on which stage you are, the major adverse cardiovascular events are differently or in varying reductions seen. So much so that statins are indicated in patients with CKD3. It's probably indicated in patients with CKD4, but not indicated with CKD5, especially those on dialysis. And that's why the recommendation is not to start if they are not on it, but to continue if they're on it. We have too few patients with CKD4 and transplants in clinical trials, so we don't particularly know what the recommendation is for those. Nevertheless, pooled analysis continued to show benefit in kidney disease outcomes, where statin therapy reduces the rate of eGFR decline by 0.41 ml per year, and particularly looking at intensive lipid lowering reduction. So the rate of eGFR declines by 0.35. And when we look at the difference in decreases for proteinuria or albuminuria, we see that there are negative values in differences. So we know that prolonged statin therapy will not affect proteinuria and will delay the progression of eGFR reduction. But moving on, what about those patients that we start on statin therapy? How frequently do we see acute kidney injury in those patients who are started on statin therapy? In other words, do statin induce or protect from acute kidney injury? Understand that when we start statin therapy, there are particular instances where acute kidney injury is higher. And these, for example, are patients post-cardiac surgery. And in the latest analysis in 2018, looking at clinical trials with acute kidney injury post-cardiac surgery, we see that there is no effect of acute kidney injury or risk of acute kidney injury in those patients post-cardiac surgery. We also hear about contrast-induced kidney injury in those patients who have undergone coronary angiogram or coronary angioplasty. In the latest meta-analysis that was recently released, they found that even at high doses of statin therapy, and this is atorvastatin, pre-treatment was actually associated with a significant reduction in the prevalence of contrast-induced acute kidney injury in patients undergoing coronary angiography. So pre-treatment with high-dose statin therapy could actually be given to these patients before coronary angiography to prevent acute kidney injury. So going back to our non-statin therapy in dyslipidemia management, I've highlighted those particular non-statin therapies that can affect or impair renal functions. And these are fenofibrate, which are potentially nephrotoxic in those who are cyclosporine treated. And if your patient has a creatinine clearance less than 30 milliliters per minute, then these patients should not be on fenofibrate therapy. Understanding again that these are in combination therapy with statin therapy unless statin is contraindicated or patients are not tolerating the statin dose. Other non-statin therapies are safe in patients with kidney disease. So the key messages for statin therapy in chronic kidney disease is that guidelines in chronic kidney disease may vary. Pooled data continue to show benefit for treatment in chronic kidney disease. There is a lack of evidence for recommendations for CKD4, 5, and transplant patients, and data for safety are likely according to stage. Thank you.
Thank you very much to our speaker for a very thorough discussion of dyslipidemia, its treatment, especially in hepatic and renal impairment. Okay, let us just update you on what is going on right now in the virtual world. We have 142 participants logged in through our live streaming and 139 participants through Facebook Live.
Okay.
Let me first thank our sponsor for today's webinar, that's Merck, Sharp & Dohme. Now, we are going to allow our webinar viewers to ask questions from our speakers, and we will be reading from your question box. Okay. I have my share of questions. Let me see first. If we should answer this, I'm a rheumatologist, and we're always told that our patients with chronic inflammatory conditions also are at a higher risk for developing cardiovascular events, and a lot of them do have dyslipidemia. Our patients are not in the risk categories that you mentioned, but is that something that we can
That's a great question.
think about?
When we look to statin therapy, we talk about pleiotropic effects aside from lowering of LDL cholesterol levels. And that's the reason why in chronic diseases, statin therapies are also instigated. So for example, in patients with rheumatic arthritis, rheumatoid arthritis, in patients with hypothyroidism, these are chronic inflammatory states. These statin therapies can also reduce the inflammation because of the pleiotropic effect of statin therapy. And so we do have recommendations for patients, understanding though that priority is going to be looking at their atherosclerotic cardiovascular disease risk. So in patients who have chronic illnesses, the priority has to be to see if they have ASCVD risk.
Okay.
If statin therapy is not recommended because they are low risk for ASCVD, then there may be a benefit to starting them on statin therapy if the chronic inflammatory state increases their risk for ASCVD.
Okay. So I think that's very clear that there's a lot of discretion actually left according to the judgment of the physician who are
Correct.
following them longitudinally. We have a few questions, and these are very practical questions. How often do you check the LFTs in someone exhibiting sub-high rule transaminitis? I think what they mean is that
Yes.
it's getting a bit elevated,
So
but
it's
not
drug
quite absolute.
hepatotoxicity
Yeah.
that we're worried about. So the recommendation is 2 weeks actually, so that you can see if there is continuous elevation. And I think it's important for physicians to see that it should not be a daily or a weekly monitoring of liver function tests. Because sometimes there will be changes in liver function tests. We call them fluctuations in LFTs. And by virtue of checking too early or not waiting for 2 weeks, then you're actually doing a disservice to your patient if this elevation or this fluctuation is a normal variant. And that's the reason why we recommend 2 weeks before you check. Having said that, in patients who are also started on statin therapy now, the recommendation now is not to keep checking every month, because in high-risk individuals, the recommendation is to keep these patients on it. I think as a knee-jerk reaction, a lot of physicians keep checking, and because of it, their patients also become aware that they're checking, and so the patient thinks, if my doctor keeps checking my liver because he started me on statin therapy, then likely it's affecting my liver. So the recommendation is, unless there is a high clinical suspicion that this patient is high risk for drug hepatotoxicity, as a rule of thumb, we don't recommend it. In 2012, the US FDA actually pulled out from the package insert of simvastatin routine LFT monitoring. We only monitor at baseline when you start them on it, and yearly, and only if these patients are at high risk, meaning they develop symptoms, jaundice, or if already their baseline LFTs are elevated, high risk for hepatitis, or they already have concomitant diseases that increase their risk for liver function.
Let me just see if I got that clear. You do baseline AST-ALT. If your baseline AST-ALT is acceptable, just do it after a year. There's
Correct.
no need to spend more money and cost more
Absolutely.
panic on the patient. But if the patient has risk or there does become an elevation in AST-ALT, you can monitor after 2 weeks.
If it's more
If
than
three
three times the upper limit of normal, plus if the total bilirubin is elevated, meaning you fulfill high rule. But if it's less than 3 times above the upper limit of normal, then these can be transient transaminitis, and there is no need to monitor these patients' liver function tests.
If the patient insists,
Yes. So, I think what's important, ma'am, when we talk to patients is assurance. When they see that confidence in the physician, that there is no need to monitor, and I tell my patients that all the time. I think the challenge with practicing in our day is that we're fighting Facebook, Twitter, Instagram. And if one patient complains of elevations of liver function tests and posts it, then every other physician is at risk for being questioned why they're not
Why you're not monitoring.
But if as a group we are confident and we explain to our patients why it would do them a disservice to keep monitoring liver function tests, then I think that can be instilled in them and they will understand why there is no need for continuous
Because it's really true. Sometimes when the physician says, okay, I have to check your liver function after a month because
Right.
maybe this will happen.
Exactly. So the patient will think, you're checking, so my liver might be at
Might
risk.
be
Then
at
they
risk.
start reading about it, and a little knowledge is a dangerous thing when we talk about it.
Okay. You talked also about patients with symptoms, and you mentioned jaundice, right?
Mm-hmm.
Most of the patients that we would actually see would complain of some vague discomfort, bloatedness. Should the physician worry about these things?
Absolutely. Well, I think what's important there is that we document it from the beginning. So understand that when we talk about statin therapy, there are a lot of things that can cause drug-drug interactions. Patients may develop myopathy. But if at baseline we've already documented what patients' complaints are, then we'll know if these are statin-induced. What's exquisite about statin-induced adverse effects is usually the effects come on after about 2 weeks. So if within 2 weeks you start noticing symptoms, if it's beyond 2 weeks, then it's unlikely caused by that new therapy that you placed, and these are statins.
So if the patient comes and says, I took the meds, after 2 days I felt this, how is the clinician supposed to interpret that?
Oh, great. So usually, I tell patients from the bat what side effects they should look for already, so that they know that in that 2 weeks, we will be observing. But I document the aches and pains, the bloatedness. If they already felt it before, then I try to tell them if there is a significant difference within that 2 weeks from what they had felt before. But I think any symptom when we're talking about statin therapy is important to document because most of these symptoms are symptoms we cannot measure.
That's right. And they can be very commonplace symptoms. Right?
Absolutely.
Yeah. Okay, there's a question here about taking liver supplements. Okay, and we have a lot of supplements that are actually marketed. With taking these drugs, maybe I shouldn't be mentioning names. Be advisable for somebody taking statins to mitigate liver injury?
Oh, great question, ma'am. And we do get that a lot. Because the transaminitis that we see when starting statin therapy is unlikely because that statin is harming your liver, then we do not recommend supplements with starting statin therapy for the liver. Having said that, there is one particular supplement that may be beneficial, although controversial in clinical trials, and this is coenzyme Q10.
Oh.
There are clinical trials that show, again controversial, that if you are on CoQ10, it reduces the risk of myopathy in patients on statin therapy. Myopathy. So, not elevations in LFTs, no protection for the liver, but it does show that anecdotally, some patients feel better. When you look at the pathophysiology of statins, we know that by inhibiting HMG-CoA, it actually also reduces the byproducts of cholesterol synthesis, one of which is coenzyme Q10. So, by supplementing them with CoQ10, because some people think that depleting their CoQ10 increases the risk for myopathy, by supplementing it, some patients feel they can tolerate the statin, but not evidence-based. Anecdotally, very conflicting studies.
So maybe CoQ10 if the complaint is myopathy.
Correct.
But sadly,
Supplements,
not likely to mitigate
not likely
transaminitis.
because the transaminitis is transient, reversible.
Okay. Now, a lot of our patients actually who have CKD are diabetic patients. Okay. And the threshold we set earlier for LDL is 130 or less for non-diabetics.
Correct.
What about for diabetics? What is the magic number we should be watching
Great
out for?
question. So when we look to diabetics, we know that their dyslipidemia is very unique in that they have what we call atherogenic dyslipidemia. In diabetics, we have high triglycerides, low HDL, and near normal LDL cholesterol levels. So by virtue of that, the magic number for diabetes is actually a 50% reduction from their baseline. Because you know that LDL cholesterol is likely to be low. If you set a number of less than 100, which some guidelines recommend, if the patient already has an LDL cholesterol of 100 at baseline, you may do them a disservice by not placing them on statin therapy because you think they've reached your goal. But the types of LDL cholesterol in patients with diabetes are the atherogenic ones. These are the ones that are sticky, they're smaller, we call them small dense LDL cholesterol, and they stick to the arteries more.
Okay.
So even though the total LDL cholesterol is not reflective of the small dense LDL cholesterol because we cannot measure them, we know these patients with diabetes need to be on statin therapy.
Even if on the surface the LDL seems normal,
Absolutely.
is there a threshold there that we should be watching out for? Should we pay more attention to the total, to the triglycerides?
Oh,
to the
great
HDL?
question, ma'am. So there are guidelines already that are saying that you should go beyond LDL cholesterol when we manage dyslipidemia in diabetics. One of which is a blood test called apolipoprotein B, which also has a goal. It should be less than 90 in diabetics. But if we don't want to spend for ApoB, which is not available locally,
yes.
then we can actually compute for the non-HDL cholesterol. And non-HDL is very simply total cholesterol minus your HDL leaves you with non-HDL. And that non-HDL goal should be 30 points above your LDL goal.
30 points.
Absolutely. So if you're diabetic or if you have CKD and you want the LDL to be below 100, the non-HDL goal should be less than 130.
Okay.
If you have atherosclerotic cardiovascular disease, you have a stroke or heart attack, and your LDL cholesterol is less than 70, your non-HDL cholesterol goal should be less than 100. 70 plus 30.
30. So 30 absolute number difference.
Correct.
Okay.
And the good thing about non-HDL is it's not affected by fasting. You can actually get non-HDL cholesterol even in non-fasting lipid profile because it's just total cholesterol minus HDL, then you get your non-HDL
I
cholesterol.
think even the mathematically challenged doctors can work on that. Okay. What about, should you treat pre-diabetic patients with statins knowing that they're at an increased risk?
Great question. So, I think the challenge, I'm a preventive cardiologist, so the challenge is actually trying to get these patients. And that's the reason why they coined several terms like metabolic syndrome, where we're trying to place patients into a category before they develop diabetes. And in these particular patients, clinical trials have shown that if you place metabolic syndrome patients on statin therapy, there is a benefit. However, our guidelines do not make recommendations for metabolic syndrome yet. We don't know if in the future that will come into play, but for now, it's still risk factor counting, and it's still trying to figure out if these patients have high risk for ASCVD. Because if you look at the local guidelines for risk factor counting, kasama sa risk natin, ma'am, yung obesity.
Okay, that's right.
Because of it, if these are modifiable factors and you don't, and you fulfill the criteria for metabolic syndrome, which is hypertension, pre-diabetes, metabolic syndrome, all of which can be counted in our list for risk factors. If the LDL cholesterol is more than 130 and the patient is more than 45 years old, then statin therapy should be started.
I hope that answers our colleague from Bataan. So we
Thank you for
have
the
to
question.
count risk. Okay. We have some interesting questions. Is there a best time to give statins and why would you recommend that time?
Oh, great question. So I get a lot of referrals for patients who are on alternate day statin therapy. I want you to understand the pathophysiology behind statins. We have 3 statins that are available: simvastatin, atorvastatin, and rosuvastatin. Simvastatin, shortest half-life, has a half-life of about 6 hours. Atorvastatin has a half-life of 12 to at best 16 hours. Rosuvastatin has a half-life of 36 hours. When your body produces cholesterol, it does it at 2, 3, 4 o'clock in the morning when you're asleep. So you want your therapy to reduce LDL surge of the liver or cholesterol surge of the liver working when you're sleeping. So if you take simvastatin in the morning, because it only has a 6-hour half-life, there's no effect by nighttime or the morning. So please take it at night.
Okay. Simvastatin at night.
Simvastatin at night. Atorvastatin, same, 12 to 16 hours. So you want it protecting your liver when it's surging cholesterol at night.
At night.
Rosuvastatin, because of its 36-hour half-life, can be given in the morning because it will protect your liver from that surge of cholesterol. Having said that, rosuvastatin should be the only statin that can be given on an alternate day dosing. Not atorvastatin, not simvastatin.
Because the kinetics will not support it.
Answer.
Right? Can I make your life a bit harder?
Okay?
What happened to call center agents or those who don't
Oh,
sleep at night?
beautiful question. So, in these particular patients, same with travel, no? A lot of patients come to me and they say, I'm traveling, when should I take my medications? When you have patients who are on rosuvastatin, it's really not a question because they can take it at whatever time they take it. And I find that that's actually the simplest to give call centers because call center agents, they change.
Yes.
1 month they're in the morning, the next month they're at night, or they're afternoon. So because of it, I tend to give them longer acting medications, not just for dyslipidemia management, but for hypertension control. If they're on longer acting agents, it doesn't particularly matter what time they take it during the day.
We have a lot more. I'll give you a quick Q&A, okay? You said that the LDL surge happens when you're asleep 2, 3, 4 a.m. What if you don't sleep? You get the surge?
Pathophysiologically, your body will because that liver needs to produce cholesterol.
Okay, so see, not sleeping is still not the solution, ladies and gentlemen.
Absolutely, that should not be the corollary to what I mentioned. Yes.
May pilosopo po kasi sa mga pasyente natin. Do you have a favorite statin that is best to use for primary prevention of cardiovascular disease? Somebody's asking.
Okay, when we look to statin therapy and we look back at primary prevention, all statins are beneficial in primary prevention. The longer you keep these patients on it, the better the benefit.
So no favorites?
No favorites.
Okay. What about patients who are post-stroke? They've had an event,
Okay.
but the lipid profile is still normal.
Oh, great question. So, same, like in diabetics,
By the time
the recommendation,
30 seconds.
the recommendation is a 50% reduction from baseline.
50% to
Yes, lay SCBD.
Do you have a special statin for them?
For stroke patients,
Post-stroke,
not particularly.
Not particularly.
No risk for ischemic hemorrhage, but benefit for hemorrhage, but benefit for ischemic stroke.
Here, Facebook says that statins can cause diabetes. True or false?
There was one particular trial that showed that rosuvastatin may increase the risk. But I want you to look at the risk-benefit profile. If I give statins, in 40 patients, I will prevent 1 heart attack or stroke. If I give statins to 200 patients, 1 will develop diabetes. So you weigh the risk and the benefit. I would rather prevent that patient's stroke or heart attack and just monitor closely out of those 200 that I started, particularly on rosuvastatin in the Jupiter trial.
Okay, so the answer is
Yes,
yes,
I
it
will
may,
still give it.
but the benefit outweighs the risk.
Yes, absolutely.
Statins cause Alzheimer, yes or no?
So, in the latest meta-analysis that looked at statin therapy, there was no increased signal for Alzheimer's disease. It's not really Alzheimer's, ma'am. It is neurocognitive development.
Okay, so not going to
None.
happen. Okay. Is there a recommended cooking oil? Is canola better than coconut, or is olive oil better than
Great
them?
question. So we get that a lot. I want you to understand that when you manipulate oil, whatever oil it is, if you heat it, it breaks the double bonds. They all become the same. So don't waste your extra virgin olive oil and heat it because it becomes the same. It's best at room temperature. Coconut oil, lot of controversy around it. The problem with coconut oil in the Philippines is we don't standardize how we are developing it. So if everyone claims they have the best coconut oil until our FDA approves particularly how we make it, we don't have recommendations. Kaya yung coconut oil, iba-iba. Yung iba tubig, yung iba konti at room temperature, right?
Yeah.
Because they're manufactured very differently as opposed to olive oil, for example, abroad where they standardize how they
Okay.
manufacture.
What about canola? Is it worth spending extra money on?
So canola, like I mentioned, any oil, if you manipulate it or you reuse it. I think ang problema sa Pilipinas, pagka ginamit yung oil, nanghihinayang, isi-save para pamprito ulit.
Sayang, di ba?
Yes,
Yeah.
but when you reuse oil, you break the double bonds, it becomes lard, so we do not recommend it. So any single use of oil, it doesn't matter which oil you're using if you're gonna heat it. But if you're gonna eat it at room temperature, olive oil, of course, is beneficial.
Okay, so cooking lesson for the day, do not reheat your oil, do not waste your olive oil for frying, use it
On pasta,
for
salad, at room
cleaning
temperature.
your food. Okay. We have one last question. What dose should they start with for patients with CKD3?
So for statin therapy, there are recommendations. The recommendation is moderate intensity statin therapy. So it depends on which particular statin you're using. So with Rosu, that's going to be 10 milligrams. With Ator, it's going to be 20 milligrams in CKD.
Is it the same even if patients are average or high risk?
So if patients are high risk, the recommendation is still a 50% reduction from baseline, especially in patients with renal impairment. But of course, we go by physician judgment if your patients can tolerate it.
Okay, so that's a lot of learning for this afternoon. Thank you very much, Luella, for those insight and information.
Thank you for having me.
Yeah, let's just summarize. You can correct me if I got it wrong. No? Yeah. Lesson number 1 is we need to pay special attention to your LDL thresholds across different populations of patients, and targets might be different according to the risk factors of the patient. And we mainly correct LDL elevations with statins, and this is not replaceable by fibrates or your omega fatty acids as baseline. Number 2, it's important actually to start these drugs even for patients with hepatic impairment, and the monitoring we need to do is an AST of greater than of greater than 3 times the upper limit of normal. That warrants watching, but don't be very scared and stop immediately if it's just a 2 times elevation, because transaminitis is better than drug toxicity. And this also applies for patients with hepatitis or non-alcoholic fatty liver disease, and they may even be beneficial really for these conditions. The third one is for patients with CKD. Statins are very helpful and are indicated specifically in CKD3, and they may even contribute towards decreased reduction of your GFR, progression of your GFR reduction. But again, treatment is primarily using statins, and most important lesson for the day, do not cook with your olive oil, ladies and gentlemen.
Sayang.
So, okay. Thank you for that discussion, Dr. Gonzales. After this session, we will be sending you an email survey link. Please do answer the survey so you can get your certificates. Please also answer in the survey so that we can improve our access on your access on our webinars and address your preferences in terms of topics and give you materials if you so wish. Thank you for joining us this afternoon. We would like to thank our sponsor, MSD Philippines, for their support of this webinar. This is weekly, so we hope to see you again next week. That's February 6, Wednesday, again 12 to 1 p.m. Manila time, with our speaker, Dr. Dennis Lee Sakdalan, and he's going to talk about all about the Big C, from screening, detection, and updates on cancer. Again, this is sponsored by MSD. Please do invite your colleagues to join us in this continuing weekly webinar series. It's probably going to be more than weekly. Watch out for it. All the schedules and resources will be posted at facebook.com/UPMedwebinars. You can also email us at the address indicated on your screen for any inquiries. On behalf of UPCM Class of 1994 and the UP Medical Alumni Society, we would like to thank our collaborator units, UP College of Medicine Postgraduate Institute of Medicine, the UP Manila Information Management Service, and AEHIN. This is Dr. Hazel Manapat Reyes with our speaker, Dr. Luella Gonzales, still the only lipidologist in the country, and the UP Medicine webinar team closing this section. We hope you have learned a lot from today's webinar. I certainly did. Join us again on February 6th and have a great week ahead, everyone. Good afternoon.
Okay, pwede na pa
Okay. Thank you. Gamit na gamit ang mga kadaldalan natin.